Welcome to our second Common Health Questions for FOP Medical Experts panel. Today, I am thrilled to be joined by five FOP medical experts from around the world. We're going to hear from each of them and we'll hold any questions that are submitted for all of our panelists to answer together at the end. First up today is going to be Dr. Mona Al-Mukaddam. So Dr. Al-Mukaddam is an adult endocrinologist in the Division of Endocrinology, Diabetes, and Metabolism at the Pennsylvania Bone Center. So Mona is going to be talking to us today about uterine fibroids, and I'll hand it over to you, Mona.
Thank you, Hope. So for today, good morning, everyone, and good morning from Philadelphia. I don't know what time it is for you guys. So as Hope mentioned, I'm an adult endocrinologist, but I've been getting a lot of questions from patients from all around the world about, feminine health issues and FOP. And so I wanted to go over some of the common questions that I keep getting asked about and some of their common treatments. And then go over, do we know anything specifically related to FOP? So the topics that I'm going to be addressing today are absent menstrual cycles. So if someone doesn't start getting their period or they suddenly stop getting their periods, what are the definitions of that and what are potential treatments? And then I also get a lot of questions about my period is so heavy, it's irregular, it's very unpredictable, and it's making hygiene very challenging as well. And if there's anything that we can do to decrease the burden of these menstrual cycles. And then we'll talk about uterine fibroids as well. So the first thing is I would like to define amenorrhea. So amenorrhea can be defined as either primary or secondary. Primary amenorrhea is the absence of menarche by the age of 15 or thereafter. So this is in females who have not gotten their periods yet at all. And by the age of 15, we start doing additional evaluation as to why the periods have not started. Secondary amenorrhea is the absence of menses for more than 3 months in females who were previously having regular menstrual cycles, or 6 months in females who were having irregular cycles in the past. The causes of these types of amenorrhea, whether it's primary or secondary, are usually hormonal, and there's a huge overlap. But any congenital defects, meaning the defects when you were born with it, or if someone was born without a uterus, then they're not going to be able to have a menstrual cycle. And that usually causes primary amenorrhea. However, with time, sometimes if someone's had surgery to their abdomens, they can get adhesions that can cause obstruction to the outlet of the uterus. And so that can cause either primary or secondary amenorrhea. Whenever we get our periods on a monthly basis or thereafter, that's being controlled by our brain. So there's a part of the brain that's called the hypothalamus and the pituitary that secretes hormones. And these hormones then affect our ovaries to produce additional hormones, and then the ovaries secrete hormone that affect our uterus. So any disruption in this pathway, whether it's up in the hypothalamus pituitary or in the ovaries or the uterus, can cause abnormalities in the menstrual cycle. So there are certain conditions like polycystic ovarian syndrome that can cause irregular menstrual cycles. Ovarian insufficiency or agenesis. So if the ovaries are not well developed, that can cause primary amenorrhea, but also with time, they can have primary ovarian failure and the ovaries stop working, and that can cause amenorrhea as well. The hypothalamus, which is up in our brain, it can be affected by multiple conditions, but also can be affected by stress and chronic illness. So we also see that in people who are severely underweight. So a lot of the stress that can happen in our lives and having chronic illness like FOP could potentially affect our hypothalamus and pituitary and suppress the production of hormones that are necessary for regular menstrual cycles. There are also conditions that can happen in the pituitary where certain hormones can be overproduced, like prolactin, and cause suppression of the menstrual cycles. So obviously, when we're talking about what are the treatment options, we really need to know what is the cause so that we can treat it. So treating the underlying cause or the etiology is very important. But we will also recognize, even if we never figure out the etiology, is estrogen is very important for bone health. So in females where we feel that the reason for their absent menstrual cycles is because they're not producing enough estrogen, we will need to replace that hormone. And if someone has a uterus, we usually add on progesterone to protect the uterus from hyperplasia. Oral contraceptives and hormone replacement therapy has been used safely in FOP patients. We do always ask them to monitor for blood clots. Estrogen and progesterone can increase risk of blood clots. And of course, in our FOP patients where mobility is compromised, that can also be a predisposing factor for blood clots. So what about heavy or painful menstrual cycles? The goals of treatment when we're trying to address that is to allow for more predictability of when these cycles are happening. Sometimes it's reduction in duration or frequency, so they end up you can get your period maybe 3 to 4 times a year instead of monthly. Sometimes it's the pain or the amount of bleeding that happens, so you want to decrease some of this menstrually associated symptoms. And some people desire complete amenorrhea so that they don't get their period at all. And there are ways that we can do that to either decrease or stop menstrual cycles. Again, using oral contraceptives or combined estrogen and progesterone pills, patches, or vaginal rings can be used. There are also pills like progestin-only pills, but they don't offer any contraception. And then there's also intrauterine devices that can be put in the uterus. Historically, I have recommended against the use of any implantable devices or any devices that need to be put in the uterus. My concern with these intrauterine devices is that you can put them in, but then if any complications happen, it's going to require surgery sometimes to remove them. And then also depending on how the hips were fused at the time of the insertion, the removal of these IUDs might be much more challenging 5 years down the line, depending on the change in the hip ankylosis. There are also non-hormonal methods to help alleviate some of those symptoms. So ibuprofen or non-steroidals can decrease menstrual flow and decrease menstrual cramping. And there are also medications that can decrease the bleeding that can happen. I just wanted to also remind you of the Ability Toolbox guidebook that is found on the IFOPA website, which goes about different tools that our patients have reported to be helpful in terms of hygiene and bathroom hygiene. So I would advise you to go on that website for any ideas of things that could be helpful. So then moving to uterine fibroids. So fibroids have a lot of names. So you might hear them as uterine leiomyomas or myomas or fibroids. So they have multiple names, but they are the most common pelvic tumors in females. And these are abnormal growths that can grow in the muscle of the uterus. They can be found in several locations, and in one patient, you can find them in all different locations. So it could be either submucosal, so this is going inside the uterine cavity, but it's coming right under the mucosa lining. And then you can have fibroids that are inside the muscle, so this is inside the muscle, or you can have it coming outside of the uterus, and these are called subserosal fibroids. In any one patient, you can have either one or two or multiple fibroids, and they could be in different sizes and different locations. What's very important is that this is not cancer. So these are almost rarely, if ever, malignancy. But they are very common. And so before this talk, actually, before last week, I used to say, the prevalence in the general population has been reported anywhere between 7 to 80%, and the prevalence definitely increases with age. And we really had no information about the prevalence of fibroids in FOP patients. But recently, thanks to you guys filling out the IFOPA registry, and just to highlight the importance of this registry, we had 12 FOP females fill out the new survey that included questions about fibroids. Those 12 FOP females were between the ages of 19 to 45. And 6 out of 12, so 50% of those respondents, FOP females, responded that they had history of uterine fibroids. So again, we cannot extrapolate that this is the actual prevalence because it's only 12 patients who have responded. But it's important to note that it was high. The prevalence was 50% in that age group. I tried to look up information in a similar cohort age group in the general population to see how does that compare. And so I found a paper that was published from Italy where females between the ages of 30 to 60 underwent ultrasound. So this is an ultrasound-based prevalence, not historical reporting. And in that study, 21% of those females reported were found to have uterine fibroids by ultrasound. So more information to follow. I think this would be very interesting to continue to pursue to see if FOP females have higher prevalence of uterine fibroids compared to the general population. But at least this preliminary finding suggests that. So what are the symptoms of fibroids? So fibroids often cause no symptoms at all, which again goes over to this prevalence question. The 50% that we have noted is people based on medical history, meaning that they probably had some symptoms related to their fibroids. So fibroids can cause no symptoms, but they often can. And so some of those symptoms could be very heavy menstrual cycles. They can cause pain, pressure, or even feeling of fullness in the belly. Because of pressure on the bladder, they feel that they need to urinate more often. And because of pressure on the intestines, they feel that they can have constipation and too few bowel movements. And it can also, depending on the location and the size of the fibroid, can affect the ability for someone to get pregnant. So similar to before, what do we do in terms of treatment? Well, it really depends on the symptoms. Are they having symptoms or not? It also depends on age. So if someone's going to go through menopause very soon, the fibroids usually shrink at the time of menopause. And so that's when the monthly periods stop. So sometimes if, depending on the age, we might have to just monitor for a little bit until menopause happens. If someone desires pregnancy, then you're probably not going to use oral contraceptives as a treatment. We can use medications to stop the bleeding or use oral contraceptives if it's bleeding that's causing anemia. And then also we look at the size and the number and the location of these fibroids. And then we always have to think about the risks of all these procedures. And that's even so much more important in FOP females than it is in the general population, because a lot of times the treatment for uterine fibroids might be surgical. There are non-surgical ways to treat this. So medicines can decrease the bleeding, but it does not decrease the size of the fibroid. So if we're having issues with belly distension, problems with constipation or excessive urination, then medicine is not going to really shrink the size of these tumors. But we have also more interventional strategies to address uterine fibroids. So surgical removal is one of them. There's also embolization, so going into a vessel and embolizing the fibroid. We don't have any experience in FOP patients. As far as I'm aware, I'm not aware of anyone undergoing this procedure. It does require sedation, and there's a higher risk of recurrence. And we don't know if the embolization of these fibroids can cause significant inflammation and potentially exacerbate flare-ups. In terms of medical therapy, there's multiple ways of doing this. So going back to this pathway of our brain controlling our ovaries or controlling our uterus, we can have hormones that suppress the hormonal production from the brain, or we can have hormones to suppress more the ovarian function. The problem with any of those hormonal therapies is that they're not long-term. So they can suppress the bleeding issues, maybe decrease a bit the size of the fibroids, but it's not a long-term solution. And the other thing about some of these hormonal therapies where suppresses the pituitary function high up is that they can have side effects. And predominantly we worry about the bone health side effects because they do suppress estrogen quite a bit. In terms of surgery, you can go in with a scope. So there's hysteroscopy. It's when you're doing a surgery within the uterus, and you go in with a scope to remove a fibroid or a polyp. You can do a myomectomy where you remove the fibroid from the muscle, or you can do a hysterectomy where you just remove the whole uterus. So again, this really depends on the desire for pregnancy. If someone wants to has a desire for future pregnancies, we're not going to recommend a hysterectomy. Whenever we do any interventional therapeutics in FOP, we really need to have a multidisciplinary approach where we have surgeons, the anesthesiologist, even post-operative care, and the ICU team needs to be aware of the patient and of their specific challenges and different ankylosing. So in terms of our experience with women with FOP, primary and secondary amenorrhea has been reported to me that I've seen in my patients. Oral contraceptives have been used successfully and safely to decrease the menstrual cycles and the burden of the menstrual cycles. We know of FOP females who have underwent hysterectomies, and those have been done as well safely. We have one case report that we have published about an FOP female who underwent a hysterectomy, and luckily her procedure was uncomplicated and no extra bone formation occurred. It is important to note that the uterus is made out of a different type of muscle, and so we don't suspect that the uterine muscle would be affected by FOP in that we don't see any flare-ups in the uterus. And now, more recently, we have some data about the prevalence of uterine fibroids. So this preliminary data suggests 50% reported fibroids, but we definitely need way more information before we can make any generalized comments. So with that, I'm going to end and move it over to Hope. Thank you.
Thank you, Mona, for that very important update. I know that your talk on feminine health issues only applies to half of our community, the females, but as you've highlighted, there was some really important information in there about the prevalence of some complications that can arise. So it's an important topic, and thank you so much for creating the time over the past year or so to put that presentation together and shed some more light on it. We are going to move on now to our second presenter. So Dr. Robert Pignolo is the Robert and Arlene Cogged Professor of Geriatric Medicine and the Chair of Geriatric Medicine and Gerontology at the Mayo Clinic College of Medicine. So Dr. Pignolo is joining us today to talk about kidney stones and FOP. And I will hand it over to you, Dr. Pignolo.
So the last time that I gave this talk in person was at a family gathering, and just before my talk, a patient of mine came up to me and said that he had just passed a kidney stone. Now, of course, I thought he was joking because of the talk I was about to give, but he, in fact, was not joking at all. And it illustrates one of the major points why we're even talking about kidney stones, and that is because they're very common and they're also preventable. Next slide. So what are kidney stones? So these are hard pebble-like pieces of material that can form in one or both kidneys. They can also form in the bladder. And they're composed of certain minerals. Usually calcium is the most common mineral that we find, but there's a variety of them, which I'll speak about in a little bit. They can vary in shape and size, and sometimes, depending on the type of kidney stone, they can be quite large, and varying colors, which often reflect the type of kidney stones they are. And also, depending on the size, they can either pass through the urinary tract, causing little or no pain, or they can obstruct ureter, and they can cause lots of pain. And of course, the larger the size, the more likely that an obstruction will occur. And so you can get decreased urine flow and severe pain or bleeding. Next slide. So I mentioned earlier that calcium stones are among the most common, and they're really called calcium oxalate stones. Those are the most common. There are also stones that are composed of calcium phosphate, um, and these are the two most common. Now there are other types of stones which are more likely in certain types of predisposing conditions. But I think for the purposes of this talk, the important point that calcium oxalate stones are the most common is that um, uh, the amount of oxalate in the diet can be modified. So there are a lot of risk factors for kidney stone formation. Sometimes when the urine flow is not as good as it could be, that can that can precipitate a stone. Sometimes chronic or long-lasting inflammation of the bowel can cause that. There are types of underlying metabolic and structural uh, kidney diseases that can predispose to kidney stones. History of digestive problems or uh, surgery of the GI tract. If you have very high levels of calcium or oxalate in the blood, if you have a condition called hyperparathyroidism, um, hyper uric, hyper uricasuria, if you're overweight, if you have repeated or recurrent UTIs, and again, if you have a metabolic predisposition that especially occurs in the kidneys called renal tubular acidosis. There are also some medications that can predispose towards kidney stones, and those include things like diuretics and calcium-based. Sorry, I just lost my screen. I just lost my presentation.
Dr.
Adam,
Pignolo, I think Adam, our technician, is trying to pull it back up for you, so I'll give
okay.
him just 1 minute. But thank
Hey,
you for being patient, and thank you
sure,
everyone for staying on the line while we troubleshoot some technical difficulties.
sure.
Just 1 second. There we
There
go.
we go. Okay. So sorry about that. So as I was saying, there's some medications that can predispose to kidney stone formation. Diuretics and some calcium-based antacids are probably among the more common medications. And then there are complications of kidney stones, including blood in the urine, pain. Um, they can precipitate urinary tract infections and even infections that are higher up in the kidneys. And with chronic obstruction, that can also cause loss of kidney function. And on the right is just an example of one of the tests that can be done to show the presence of kidney stones. This is actually a CAT scan, and I've drawn two arrows where you can actually see the kidney stone. It's here, and this is the same kidney stone right here. So they're quite big. This is the kidney, and you can see that in this particular case, it's readily visible, and it's not small at all. Okay, next slide. All right, this is getting back to the purpose of even giving the talk, and that is kidney stones or nephrolithiasis, which is the medical term. They're very common, and we know that from two studies. One that was conducted in 2004, and another based on the Clementia Natural History Study in 2016. So in both studies, the percentage of individuals reporting kidney stones was between 8 and 9%, and these are responders who reported at least one kidney stone. The median age was, depending on the study, either in the 20s or 30s. That's not to say people who are younger or older can't also form kidney stones. We know from both studies that that those with kidney stones have increased urinary tract infections. So there's, as I mentioned earlier, there's a relationship between that. Some kidney stones are due to urinary tract infections, and sometimes you can get urinary tract infections because of kidney stones. So there was a slight male predominance, and some individuals reported multiple kidney stones. In one study, up to more than half of individuals reported more than one kidney stone. And even though both studies looked at immobility in slightly different ways, both studies confirmed that a majority of those who suffered from kidney stones suffered ambulatory immobility. And that's important because whenever someone is immobilized, whether it's because of a stroke or in the case of FOP because of locked joints, the turnover of bone in the normal skeleton and also in the heterotopic skeleton increases, and when that happens, calcium and phosphate are released into the blood. So basically, when you unload the skeleton for whatever reason, you get a higher bone turnover, and that can contribute to higher levels of especially calcium and phosphate. So just to summarize what these two studies reported, again, a high prevalence of kidney stones, especially in males, over 50% with multiple stones, and the stone formation may be associated with greater immobility. Next slide, please. Okay. So based on one recent report, which compared individuals with FOP with who had kidney stones with age and sex match weighted prevalence in the general population, it was as high as 15, almost 16%. These are adults now, so it's a subgroup here. And so that translates into approximately threefold greater prevalence of kidney stones than in the general population. And so, as I mentioned, it's not clear if the big difference is due to the high turnover from chronic immobilization, or maybe, and we can't prove this one way or another, maybe it's related to unknown effects of the activating mutation in FOP. Next slide, please. Great. So how can we prevent kidney stones? Um, so in this case, really prevention is no different in the FOP population as it is in the general population. And there have been a lot of studies which confirm these preventative measures as being effective. So if you were only going to pick one thing to do in order to prevent kidney stones, it would be to drink a lot of water. So in a very large study, drinking between 1.5 and 2 liters of fluid a day, and by fluid I mean water, it virtually prevented kidney stone formation just by that one intervention. The other interventions which make a big difference would be not having a high protein diet. So sometimes specific diets like the Atkins diet calls for high protein intake. That would be a very bad idea in individuals with who are predisposed to kidney stones. It also could. You don't have to be on an Atkins diet to get a lot of high protein in your diet. So I don't want to give the impression that you only get high protein from a special diet that focuses on high protein intake and in this case low carbohydrate. Just to make the point that in general, the higher your calorie diet, the more protein you're going to get. Now, this is not to say that those who have nutritional issues, either because, of an ankylosed jaw or for other reasons, they shouldn't get enough protein. I'm talking about individuals who have no problem getting enough protein and, in fact, get too much in their diet. Here's something that's not intuitive. So reducing calcium in your diet because you think calcium stones are the most common, and if you stop taking calcium, you're actually going to prevent stones from forming. That is a myth. In fact, if you reduce calcium in your diet below normal recommended doses, you actually predispose yourself to getting more kidney stones. So that's not to say that if you take excessive amounts of calcium, that doesn't predispose you to kidney stone formation. It just means that you need a normal calcium intake, and you shouldn't try to reduce the amount of calcium. In fact, most people cannot get all or do not get most of their calcium requirement through their diet anyway. And so for reasons unrelated to kidney stones, it's also important to maintain a normal calcium intake. And then the last preventative measure, if you know the composition of the kidney stone stones that you pass, you can take dietary measures to reduce the intake of foods that are rich in certain types of either minerals or other substances that precipitate kidney stone formation. And so the best example I can think of is oxalate. So calcium oxalate crystals I mentioned earlier are the most common kind of kidney stone. So oxalate is in a lot of foods that we eat. And so one intervention would be to reduce the amount of oxalate-rich foods. And then finally, I want to make the point that sometimes the pain associated with kidney stones can be confused with flare-up symptoms, but I think once someone has a kidney stone, it's very clear that even though the pain may be as intense as a flare-up might be, that the type of pain, the colicky type of pain that you get with kidney stones, the acuteness of the pain, but also the distribution of the pain, it being flank in nature, and sometimes you can actually feel the pain move. And then if you're able to pass the stone into the bladder, you get a relief of the symptoms. So So even though perhaps initially there might be some confusion with flare-ups, it's a very distinct type of pain that's associated with kidney stones. Next slide. Okay, well, I'm going to send this back to Hope, and thank you.
Thank you so much, Dr. Pignolo, for that overview and those preventative measures to help families avoid what you shared can be a very painful complication. So we appreciate your update on that. And now we are going to turn to Dr. Vrisha Madhuri, who is the Ida Scudder Chair of Clinical Research in the Pediatric Orthopedic Department and Center for Stem Cell Research at the Christian Medical College in Vellore. And Dr. Madhuri is going to be joining us today to talk about some of the different diagnostic journeys that families in India have had and how their unique FOP symptoms have impacted those journeys. So over to you, Dr. Madhuri.
Hello, everyone. I'm just digressing from the general tone of this session by addressing some of the challenges that are faced by the LMIC patients and the medical professionals who manage them. So this is basically, we are going to talk about the Indian experience in FOP. And this for me started in 1998 when I first saw a child who had stiffness of the back with some a fibrous band running across the back and limitation of the movement, which was being discussed in my department. And the plan was to go and do a biopsy on this. I noticed the toes, and since my pediatric orthopedic textbook said that these toes are characteristics of FOP, I pointed them out and tried my best to prevent the biopsy. But despite that, it happened. From that time onwards, it actually set me on a path to go and look more and more for FOP and start treating FOP. Otherwise, as an orthopedic surgeons, we don't normally treat FOP, but I entered that path because of that. Next slide, please. Next slide, please. Yeah. So this is some of the stories that I'm going to talk about. This is a 9-year-old boy. He had a gradually increasing stiffness of the back, and he came because he was unable to squat for the Indian style toilet, where you really have to go down on your haunches. Next slide, please. So this is the problem that he had. We X-ray, nothing much was seen. However, as we were looking at him, next slide, please. We noticed that he had a peculiar foot deformity. Next. And looking at these toes, it was very clear to us that this child had FOP, and therefore we were able to give advice. And remember, most of these patients travel thousands of kilometers in India and sometimes from the surrounding countries like Bangladesh and in Middle East also. And therefore, they are not always able to get the treatment that even when you advise. So we usually send them with a pamphlet, which I will share later, which they can share with their local physicians for any kind of acute episodes that they may have. Next slide, please. So these were his toes. This is the classical deformity that you see, and I know that you are familiar with it, so I won't go into more of this. Next slide, please. And he had obvious ossification, which would have been noted actually very easily if he had come and had his shirt taken off. Next slide, please. And when you take off the shirt, you can actually see these classical bumps all the way on his back. Next slide, please. So this was reported at our annual conference. And after reporting, I found in the next couple of years, at least in the next 6-7 years, at least 2 members called me back and said they have a patient with these toes and stiffness, and what should they do about it? And we were able to advise them. So I think that did help. Next slide, please. So this is another boy who presented who had a swelling over the nape of the neck in my institution, not in my department, but a pediatric surgery department, with a bony heart consistency fixed to the underlying bone and restricted neck movement. Next slide, please. So he was diagnosed to have a lesion there. They were not quite sure what it was. It's a soft tissue lesion. They were thinking of sarcomas also. So they did a biopsy. Next slide, please. And actually, the biopsy was done. As you can see, a small scar in the neck, and he developed further lesions lower down in the back, which were again biopsies. And then a search was made for this cause. because the biopsies were not diagnostic. Next slide, please. You can see these nice lesions or bony lesions under the skin. Next. Yeah, and you can see actually even in the previous x-rays, by that time you can see the ossification in the back of the neck. Next slide, please. And needless to say that he had these toe lesions all along, and this was missed. He already had by then developed a right elbow restriction of movement as well. Next slide. So we were able to do a genetic mutation analysis on that, because by that time that was available, and we confirmed the diagnosis. Not that it need any confirmation, because the clinical features were quite characteristic in this. And we did point out to all the relevant professionals that biopsy is contraindicated in FOP, and clinical examination to find the typical foot lesion should be the key to the diagnosis. Next slide. So since most of the patients come from very far, and even if we tell them when they go back, many of them are not able to speak English. We actually, since most doctors in the subcontinent study in English and can speak English, we actually make a pro forma, and which has been getting revised, and we send it to them. It's just one small page which says what all has to be avoided, and what to do for acute episodes, and what to do when the acute episode settles down and they still continue to have some mild inflammation. And so this we send it with every patient, because we do not know whether they'll be able to get to us in time. And some patients whom we know we can do video consultations with, we actually send them with a small packet of steroids for 4 days, as well as celecoxib for about 10 days to 2 weeks with them, so that if they have an acute episode, they can call us, we can discuss with them and start them on steroids. Next slide, please. This is a story which is very sad, and I relate to this very much because it's an orthopedic patient. He had an injury to the elbow and he developed myositis ossificans. And he was 14-year-old when his first symptoms had started. This was the first thing that happened. With this new bone around the elbow and the restriction of movement, he underwent a very reputed orthopedic center where surgery was done, and he developed more bone. Next slide. And subsequently, the surgeon, after the first surgery, the surgeon was able to recognize that it was a FOP patient. However, they went on to do 13 more additional surgeries under steroid covers for this child. Each time he actually got little worse. So he has actually all the classical features. He has a toe deformity, and he's now totally stiff. Even though the short toe deformity was there, it didn't prevent further surgical intervention. So he's stiff at his hip, he's stiff at one knee, and he's stiff at his shoulders, one of the elbows, and his back. Next slide. So we have a video recording of him, and he says, I was operated 13 times. Each time I became worse after surgery. Now he has actually huge amount of stiffness of his respiratory muscles also. So he has difficulty. He has shortness of breath when he walks for long or climbs steps, and has poor pulmonary function. Next slide. So we have taken this message to several forums, orthopedic, general, and pediatric meetings. We took it to the children's surgical meetings, and we have taken it to the pediatric tumor meetings, because these patients do present in ways where these surgical, basically, I think it's the surgeons who do the surgery. So I think if we can take it to the surgeons, it can be avoided. Unlike the rest of the world, where only 20 to 30% of the patients have a surgical misadventure, in our experience, almost 90% of the patients have had a surgical misadventure. Next slide, please. So this is the thing that we have actually circulated and to some of the forums, and presented this also, asking people to look at the toes before they cut or poke. So mainly aimed at a program towards the surgeons, especially pediatric surgeons and nurses. Next slide, please. So there are other differential diagnoses that are entertained, but I think toes is something which is very characteristic. So even if a surgeon is thinking of other things like a myositis or a juvenile fibromatosis, or even sometimes osteosarcoma, when they see small ossification and lumps starting, they should look at the toes before they think about doing surgery. Next slide, please. So most of the time, the presentations and diagnosis lumps, restriction of movement, foot deformity, lump formation after trauma or fever or reaction to overexertion of a particular limb or part, for example, painting followed by some shoulder and arm pain, and after playing football in small children, and trismus after the dental procedures. These are the various ways which I found that some of the Indian reported cases had presented. So I think these are all things which need to be taken into account by first always looking at a patient's hands and feet before we go on to treat any kind of a surgical condition. Next slide. So, is the classical, one of the things that we keep asking is the classical foot deformity present in all? We found that it wasn't present in all. We had hallux valgus and short toes in most, but we had reduction of digits with fusion of the phalanges in some of the atypical FOP cases. We had some patients with straight toes and even longer than normal toes. And so it's not always, it's in rare cases, you don't get the classical toe deformity. However, the X-rays usually are a little more